اوكي دكتور عبير.
Bismillah ar-Rahman ar-Rahim. Hello everyone. My name is Abeer Al-Ali, ophthalmology consultant at Sheikh Khalifa Medical City, Pediatric Ophthalmology Division. I would like to welcome you all. Today I'm coming live from Abu Dhabi. It is 8 p.m. so good evening. It is 6 p.m. in Cairo and 6 p.m. in Cape Town. Welcome to Emirates Ophthalmology Society webinar coffee break at Pediatric Ophthalmology Clinic. We will discuss all about basic topic in the field of ophthalmology, pediatric ophthalmology and strabismus. We are here today to share the information and the knowledge in simple, straightforward way. You know, all of us are work in progress in our career. Today, you will hear from the expert who influenced and continue to influence many people, including myself, to understand pediatric ophthalmology and strabismus better. In a moment, I will introduce our distinguished speaker, but before that, please allow me to express my gratitude to the Emirates Ophthalmology Society, President and Vice President, especially Sheikh Dr. Noor Al-Qasimi, and the Head of Scientific Committee, Dr. Omnia Hammam. Finally, special thanks to the host organizing events today. Thank you very much, RM Events, and thank you very much, Novartis. Our founder of United Arab Emirates said that the real asset of any advanced nation is its people, especially the educated one. And people are measured by the standard of their education. Please allow me to introduce our distinguished speaker, Nihal Shakankir from Cairo, Christopher Tinley from Cape Town, Irfan Khan from Abu Dhabi, and Abeer Al-Ali, I'm also from Abu Dhabi. Professor Nihal Shakankiri, she's a professor of pediatric ophthalmology and Faculty of Medicine, Alexandria University in Egypt. She developed special interest in pediatric ophthalmology in the year of 1995 to mark her first step in doctorate degree thesis about evaluation of heparin service modified IOL in children. She then continued a lifelong commitment to pediatric ophthalmology by a series of research topics in different aspects of pediatric ophthalmology with special interest in pediatric cataract. Some of her publication appears in international journals and journals of the domain of molecular and clinical genetics. In 2007, she founded the Association of Children's Eye of Alexandria, a non-profit organization concerned with the fundraising sponsor every possible activity related to children's eyes. Thank you very much, Prof. Nihal. Our second distinguished speaker, Dr. Christopher Tinley. Dr. Tinley is a Moorfield Fellowship trained pediatric ophthalmology who has been a head of department in Red Cross War Memorial Children's Hospital, Cape Town, since 2011. His is one of the busiest outpatient department in the hospital, seeing between 6,300 and 7,800 children and performing 650 to 750 children eye surgery annually. He is president of South African Society, Pediatric Ophthalmology Strabismus, and such advocate for subspecialty in both national and international platform. And I was honored to be his previous fellow trained in Cape Town. Thank you very much, Dr. Christopher Tinley. He also has affiliations with the CyberSite and Orbis International, and serves these organizations as an online mentor and lecturer. The third distinguished speaker, Dr. Irfan Khan. Dr. Irfan Khan has a dual certified ophthalmology fellowship. He's working with us in Sheikh Khalifa Medical City. He completed his ophthalmic residency at Manchester Royal Hospital in UK. He further specialized in pediatric ophthalmology at Manchester, and then subsequently attained another fellowship in pediatric ophthalmology at Sick Children Canada, Toronto. Thank you very much, Dr. Irfan, for joining us today.
Thank you. Thank you very much. Thank you, everyone, for attending us. Let me have the pleasure of introducing Abeer Alali. Abeer Alali is one of our colleagues, and we're very fortunate to have her at SKMC Abu Dhabi. She graduated from the Arabian Gulf University in Bahrain, and since then she realized that she wanted to devote herself to pediatric medicine because of her love for the children and the joy that she finds in caring for their health and their well-being. She continued her passion, and she got accepted as a fellow in pediatric ophthalmology and strabismus at the Red Cross War Children's Hospital at Cape Town in South Africa, and graduated in 2019. She's also actively involved in our ophthalmology residency program, and currently she's working at SKMC Sheikh Khalifa Medical City for almost a decade, since 2010. Let me go straight on to the agenda for today. Can we have the next slide? Yeah, so our first speaker would be Dr. Nihal. Dr. Nihal is going to talk about the pediatric cataracts. So Dr. Nihal, over to you.
Thank you.
So if you could just share your screen, Dr. Nihal, and you can start your presentation then.
Just of housekeeping while Dr. Nihal is preparing her presentation, please note that we will defer all questions at the end. So if you have any question, please keep it on the question and answer section. Thank you.
Is it available now?
Yes.
Screen? Okay. Bismillah ar-Rahman ar-Rahim. I'm going to speak about the management of congenital cataract. This lecture actually is dedicated to young ophthalmologists and general ophthalmologists who are going to work simple pediatric cataract cases, including the indication, the surgical techniques for these congenital cataract cases, whether you go for anterior or posterior approach, whether you're going to implant or not implant at time of cataract surgery, and after surgery, what type of frames do you use, and what type of glasses, preferred types of glasses to use in these children in order to attain and perform a good and successful cataract surgery. To start with the indication for surgery. Surgery is indicated if you can measure the visual acuity in a child, then surgery is indicated if vision is less than 6/18. So 6/18 vision with the accommodation is preserved is better than 6/6 without accommodation. If the cataract is total, whether unilateral or bilateral, if the cataract is associated with squint or associated with nystagmus, it means that it is visually significant and you have to go for surgery immediately. If there is resistance to occlusion, in cases of unilateral congenital cataract, when the baby resists occlusion of the normal eye, it means that he has a defective vision with the eye with a cataract. So you have to go for cataract surgery. If there is obstruction of the central 3 to 5 millimeter red reflex on ophthalmoscopy, you do direct ophthalmoscope in the central part of the pupil, and you see if there is obstruction of 3 millimeter to 5 millimeter, it is indicated for surgery. So this opacity is not involving the central 3 to 5 millimeters, so it is not indicated for surgery. These opacities involve 3 to 5 millimeter, but they are not dense. They don't obstruct the visual axis, so not indicated for surgery. This is a peripheral opacity. It does not obstruct, so it is not indicated for surgery. However, there are always exceptions. This is a peripheral opacity due to persistent fetal vasculature. Yes, it is peripheral and the central part is okay, but actually it is indicated. Why? Because it makes a sort of a corrugation to the posterior capsule, leading to irregular astigmatism, which is embryogenic, so we have to go for surgery. This is a central small opacity, less than 3 millimeter. It is not indicated for surgery, but take care. This one is not indicated, but that one is indicated. Why? Because you have to specify where is the site of the opacity. The first opacity is related to the anterior pole of the lens. It is anterior polar cataract, away from the nodal point, so it is not indicated for surgery. The second opacity is related to the posterior capsule. It is posterior polar cataract, near the nodal point, so it affects the vision, and that's why it is indicated for surgery. So if you're going to work pediatric cataract surgery, you should have a handheld slit lamp in order not to diagnose only the morphology of cataract, but also decide where is the site of the opacity. This is anterior polar cataract, which is not indicated for surgery. You have to focus slit lamp examination also on the posterior capsule. Look here, there is a tiny opacity on the back surface here of the lens in the posterior pole, the same axis with the anterior polar cataract. So it becomes indicated for surgery. That's why you have to focus at the anterior and the posterior capsule at the same time. This is a lamellar cataract that does not obstruct the visual axis. It is not indicated. And the other one obstructs the visual axis, so it is indicated. But sometimes we have opacities like that. We cannot judge. The child is uncooperative. We cannot measure the visual acuity. There is no squint, no nystagmus. So how to decide whether to go for surgery or not? Here comes the last indication for surgery, which is poor visualization of the macular area by indirect ophthalmoscopy. You go with direct ophthalmoscopy. Don't use the indirect, because the indirect gives you a good visualization of the macular area. Use the direct ophthalmoscope. If you can see the retina and the macular area and the fovea perfectly through this opacity, so the baby is seeing you perfectly, there is no need to go for surgery. But if you look through this opacity and you cannot see the foveal details and the macular area properly, so the baby cannot see you properly, so you have to go for surgery. As you all know, that these opacities are not indicated for surgery: the anterior polar, the coronary cataract, the sutural cataract, and the blue dot cataract. But don't drive the patient away and tell the parents it is not indicated for surgery. No, you have to follow up these cases for life. Why? Because sometimes when you have here a lamellar cataract and it is a faint one, it is not indicated for surgery. You see these examples, a lamellar with a peripheral opacification and different degrees of opacification, taking half here or maybe 3/4, but still they are not indicated for surgery. Along years, we've been observing congenital cataract for more than 30 years. There is quite evidence that these opacities or congenital opacities change with time. Sometimes there is intralenticular calcifications inside the lamellar cataract that change over time, and these are against red reflex. And not only this, sometimes it is associated with other congenital lenticular opacities both together. For example, lamellar with a nuclear cataract that also change with time. And these here opacities against red reflex. Sometimes we have a double lamellar opacities, or maybe a half a lamellar, or maybe a 3/4 lamellar. There is quite evidence along the years that they change with time. If you see here, this is less than half, more than half, 3/4, more than 3/4, or opacification of the lamellar part of the opacity of the lens. Even diffuse lamellar opacities like this may change over time until there is total opacification of the lenticular opacity, of the lamellar opacity. It may change even to calcification, calcified lamellar opacity, or it was a lamellar opacity and changed to total. or even intumescent cataract. As for example, this girl, she was diagnosed during infancy with a faint lamellar opacity, and she was told it is not indicated for surgery to her parents. Until she developed this total cataract, but they have the concept, it is not indicated for surgery. And the child, you can see here, there is a forehead. Spoke-like cataract. Spoke-like cataract, definitely these cases are not indicated for surgery, but see, that may develop another types of cataract that becomes indicated, even total cataract like that. Sutural cataract, in 99% or even 100%, they are not indicated, but sometimes they're associated with other lenticular opacities that become indicated for surgery, even proceeding to total cataract. Anterior polar cataract, yes, it is not indicated for surgery, but when we have a large anterior polar cataract, and this anterior polar cataract, we call it, in this case, pyramidal cataract. Can you look here? This is a pyramidal opacity protruding like a pyramid in the anterior chamber compared to the conventional anterior polar cataract. When you have these pyramidal opacities, meanwhile, it is not indicated for surgery because it is small related to the anterior capsule and less than 3 to 5 millimeter opacity. But please follow up these cases for life because they may develop another types of subcapsular opacities that become indicated for surgery. For example, this is a pyramidal cataract. As in this baby, few months later, she developed intermittent exotropia. Why? Because the pyramidal cataract now associated with subcapsular opacities, and we had to go immediately for surgery. And here, 13 years after surgery, she's doing fine and perfectly okay and having 6/6 vision. Why? Because we did follow up her closely and immediately go for surgery whenever it is indicated. Look to this opacity, it is not indicated for surgery. This is a lamellar opacity not indicated for surgery. All these are types of lamellar opacities that are not indicated for surgery. But take care. Sometimes they are indicated. Why? As in these twins, when it is associated with a lenticular anisometropia, lenticular myopia, they become indicated for surgery. As in these babies, they had anisometropia of -8. So you go for the cataract surgery, not because of dense opacity, but as a refractive surgery. This is anterior polar cataract again, not indicated for surgery. Don't forget to do refraction in these cases, because sometimes anterior polar cataract is associated with anterior lenticanus, especially in syndromatic cases. This anterior lenticanus may be associated with irregular astigmatism that is not amenable to be corrected with spectacles and become indicated for surgery. The second thing is that you have to go for systemic evaluation of these cases. So you have to have a good pediatrician with you and a pediatric geneticist. For example, here a bilateral congenital cataract together with jaundice and hepatosplenomegaly, you have to know that this is a cytomegalovirus infection. So you have to control first the systemic condition before going to congenital cataract surgery. This is a bilateral congenital cataract. Routine lab investigations are perfect. So you have to go for surgery? No, but take care. This is associated with carpopedal spasm. It is a hypoparathyroidism. If you go for surgery without knowing the etiology, complications may occur and the child may die from tetany on table. Another thing here, this is a bilateral congenital cataract, and it is diagnosed as galactosemia. We know that in some cases of galactosemia, the cataract is reversible when the child is on a galactose-free diet. So if you go immediately for surgery without knowing the diagnosis, you would have done unnecessary surgery to this infant. Another baby with skeletal anomalies in the hand like that, and look here to the X-ray, there is absence of radius. So this is what? This is a TAR syndrome, thrombocytopenia. If you go for surgery for these children without knowing the diagnosis, you would have intractable hemorrhage during surgery. As you see here, the child, after surgery, there is subconjunctival hemorrhage. And here, a few months after surgery, and after 1 year, because we know the condition now, and we did prepare properly the child, going for cataract surgery to her brother, few months after surgery, 4 years after surgery, we did secondary IOL implantation. 6 years after surgery, and 8 years after surgery, he came walking by himself, totally independent, seeing perfectly, and walking with straight eyes. So it is something beautiful to work as a team also with a pediatrician, with the orthopedic surgery in order to achieve these beautiful results. You have to go for control before surgery, control of any septic focus. If you have boils, you have to go for treatment of these infections before surgery. If you have conjunctivitis, if you have any lacrimal problems, like in this baby with Peto syndrome or trisomy 13, having congenital cataract and congenital glaucoma. This baby having a pyocele of the lacrimal sac. So we had to go for a DCR, and she was the youngest baby to go for a DCR before proceeding with the cataract and the glaucoma surgery. And now the second part is the surgical techniques. How can we go for a simple pediatric cataract surgery with IOL implantation? In these infants, we start first with a side port and then inject the viscoelastic, and then you go with the second MVR to make the second side port, and then lastly, you make the main one with the keratome. Why? Why you don't start by the keratome? Because if you start by the keratome, sudden collapse of the anterior chamber will occur, will close the pupil, and you will touch the pupil during surgery. This will increase the risk of inflammation after surgery. Anterior capsulorhexis. To avoid this terrible picture of capsular phimosis that may occur after pediatric cataract surgery, you have to follow these rules. First of all, in total cataract, we use trypan blue stain. I don't use it routinely, but only in the cataract where you cannot see the red reflex. In order to make a sort of a contrast between the anterior capsule and the cortex while performing the anterior capsulorhexis. And this is how to go for the anterior capsulorhexis. With a cystiotome, you make a small tear in the anterior capsule. And then with a microrhexis, it's better to use the 23 or even the 25 gauge rhexis in these infants. And then you go for the rhexis. You pull tangential, and sometimes you have to pull towards the center because the capsule is extremely elastic. You have to pull towards the center to achieve a 5 millimeter anterior rhexis. And it should be exactly 5. But when you have a lamellar opacity like that, it is well known that these lamellar opacities are 5 millimeters in diameter. So it's gonna be a beautiful landmark for the rhexis. You follow the landmark of this lamellar opacities until you achieve a perfectly 5 millimeter anterior rhexis. What if you have opacified lamellar opacities? In this case, you make the rhexis just outside the lamellar opacity, and you're gonna have this beautiful 5 millimeter anterior rhexis. Why 5? 5 millimeter because when you implant the intraocular lens inside the capsular bag, the IOL optic is 6 millimeter. So the anterior capsular rhexis will just lie inside the IOL optic. What if you have a small anterior rhexis? You have to enlarge it. How? You cut the edge of the anterior capsular rhexis, you make a cut edge here, and then with the rhexis forceps, you can enlarge it easily into 5 millimeter rhexis even after IOL implantation. Hydrodissection. Hydrodissection is very important in pediatric cataract surgery. You go with the spatula just underneath the anterior capsule, proceed to 6 o'clock position, and then elevate the anterior capsule and inject. You're gonna see viscoelastic coming outside the wound. You will not see any disturbance of the morphology of the cataract. It means that you did a perfect hydrodissection. And then you go for hydrodelineation, but take care. In some infants, look to the morphology of cataract. Can you see this ring? This is a posterior capsule defect. Look here in this infant, look to the left eye. Here at time of surgery, can you see this ring? This delineates a posterior capsule defect. Another case, can you see this elliptical halo? It is a congenital posterior capsule defect, and it is very common. In these cases, it is contraindicated to go for hydrodissection and hydrodelineation. Otherwise, all lens matter will fall into the posterior segment, increasing the risk of vitritis and increasing the risk of secondary glaucoma in these cases after surgery. Irrigation aspiration. You have to go for a meticulous irrigation aspiration, complete irrigation aspiration. Why? In order to prevent secondary cataract in the future. And you have to go for polishing of the back surface of the anterior capsule with a cannula like that. You have to polish the anterior capsule. Look here, this part is polished and this part is not yet polished. And these are remnants of lens epithelial cells on the back surface of the anterior capsule. See, this part is polished and this part is not yet polished. You go for polishing until you have a crystal clear anterior capsule like that. Here, look here with magnification, no lens epithelial cells. With more magnification, not a single lens epithelial cell. Why? You want to have a crystal clear anterior rhexis after surgery, because if you don't polish the anterior capsule will become fibrosed like that, preventing good visualization of the retina and good examination of the retina when required. And also, less than 5 millimeter anterior rhexis and not polishing, you will see this terrible picture of capsular phimosis and fibrosis of anterior capsule, necessitating secondary surgical intervention. Moreover, if you have a beautiful surgery without polishing of the back surface of the anterior capsule, lens epithelial cells will grow over the anterior surface of the lens, partially obstructing the visual axis, so we have to aspirate it again. Look here, after aspiration, we have a beautiful surgery. We have a posterior rhexis and lens epithelial cells stopping at the edge of the posterior rhexis. How to perform the posterior rhexis? It's very simple to go for the anterior approach and perform the posterior rhexis. It's not a difficult surgery, but when you follow the rules. Number one, don't inject too much viscoelastic into the capsular bag. Make the iris plane, the anterior capsule, and the posterior capsule all in one plane. And then with the cystotome, you don't dip the cystotome into the vitreous. You hook the posterior capsule. This is called hooking. And then you tent it, pull it towards the anterior chamber, tenting of the anterior capsule, and then tearing the posterior capsule into triangular tear. And it should be triangular tear. If you see it rounded, it means that vitreous did prolapse into the anterior chamber. And then through this triangular tear, you go with a viscoelastic cannula. Don't go into the vitreous, just at the edge of the tear, and you inject. If you see a circular halo like that increase in diameter, it means that you are injecting in the right space, into the Berger space. If you see injection, if you put the injection too deep into the vitreous, you will see irregularity like that. It means that you did inject the viscoelastic into the vitreous, and this will make the posterior capsulorhexis very difficult to perform. Here again, hooking, tending the posterior capsule and then tearing the posterior capsule into triangular tear. And then through this triangular tear, you get the cannula. At the edge of the tear, you do inject. Can you see this is a circular halo that increase in size? And then through this triangular tear, you can perform the posterior capsulorhexis. Very simple and very easy. And you should aim for exactly 4 millimeter posterior capsulorhexis. Anterior vitrectomy. You don't want to see this terrible picture of vitreous in the anterior chamber after surgery. So how to proceed with a simple and easy vitrectomy? You go with the cutter, first dry vitrectomy, and then introduce the irrigating cannula. Don't introduce the irrigation from the start. You will not need any steroids to inject in order to see the vitreous. Why? Because you can see the effect of vitreous. See here, there is kinking of the posterior capsulorhexis. So you have to go again for dry vitrectomy to clear the vitreous. This is not enough. Look here, the edge of the posterior capsulorhexis, it is still kinked. So you have to go for dry vitrectomy again until you have a perfectly circular posterior capsulorhexis. Inadequate vitrectomy, years after surgery, what's going to happen? Lens epithelial cells will grow over the remnants of anterior vitreous face and even occlude the visual axis despite the presence of posterior capsulorhexis. But when you go for a perfect anterior vitrectomy, lens epithelial cells after years will stop at the edge of posterior capsulorhexis, and you're going to have a beautiful crystal clear visual axis. Even when the size of posterior capsulorhexis is small, with good anterior vitrectomy, lens epithelial cells will stop at the edge and you have a crystal clear visual axis. IOL implantation, you inject the viscoelastic inside the capsular bag. You can use both intraocular lenses. The single piece intraocular lens, you can inject it safely inside the bag between the anterior and posterior rhexis, or you can use the multi-piece intraocular lens, but take care. The key of success is the lower haptic. The lower haptic should be just underneath the anterior capsule, and then unfolding of the intraocular lens rotated between the anterior or posterior rhexis, and there is a much easier technique for the multi-piece. Here, introduction of the multi-piece, the lower haptic just underneath the anterior capsule. Then you want to push this haptic optic junction forward until the intraocular lens is inside the bag. Then what to do in this upper haptic? Look here. You take midway between the haptic optic junction and the edge of the haptic. Use a Y-shaped spatula. Midway, push forward until the haptic optic junction inside the capsular bag. Leave, the intraocular lens will be exactly inside the bag, between the anterior and posterior rhexis. So we can use the single piece or the multi-piece intraocular lenses in pediatric cataract surgery. And finally, wound closure. All wounds should be closed. Otherwise, you will see this terrible picture of fibrinous reaction after surgery when leaving a soft eye in pediatrics. For example, single piece intraocular lens, few weeks after surgery, few months after surgery, few years after surgery, crystal clear lenses between the anterior and posterior rhexis. Years after surgery, see the lens epithelial cells, but clear visual axis. Lens epithelial cells stop at the edge of posterior rhexis. Here, a colony of lens epithelial cells. 5 years after surgery, 10 years after surgery, extensive pearls. 10 years after surgery, extensive pearls, but with clear visual axis. The multi-piece intraocular lens after surgery, few weeks after surgery, years after surgery, 5 years after surgery, 10 years after surgery, extensive pearls, extensive fibrosis, but we have clear visual axis. If we come to the cataract surgery without IOL implantation, in infants where we plan to go for the cataract surgery without IOL implantation, and we're gonna fit these babies with aphakic spectacles. These children, we do only two corneal ones using MVR knife 20 gauge. And here, the anterior axis should be exactly 6, not 5, because we are not going to implant, and should not be more than 6, as we're gonna see. The posterior axis should be exactly 6. And then we have to go for a very good anterior vitrectomy. And finally, we close the wound. Why? Why we go for a 6 and 6 millimeter anterior and posterior axis? Because if we go to the conventional 5 and 4, what's gonna happen? By time fibrosis of the anterior and posterior capsule will occur and it will shrink. If it is less than 6 millimeter, capsular phimosis may occur after surgery, obstructing the visual axis, necessitating secondary surgical intervention to clear the visual axis. As in this case, can you see a capsular phimosis requiring secondary surgery using a micro scissors to cut the fibrosis and to eat up the fibrosis in order to clear the visual axis? And why not more than 6 millimeters? Because if you go for a larger anterior and posterior axis, at time of secondary IOL implantation, look here, the capsular support did retract. It did retract. So the secondary IOL will be difficult. So smaller than 6, the capsule will contract. Larger than 6, the capsular ring will retract. Look here, at time of secondary IOL implantation with dilatation, the capsular ring is retracted and the secondary IOL is done in sulcus and rotated with a little bit difficulty. If you're not experienced enough, it may fall down into the vitreous. And why anterior vitrectomy is very important in these infants? Because if you go for a beautiful rexis, but without vitrectomy, good vitrectomy, lens epithelial cells will grow over remnants of anterior vitreous space and sometimes will block the visual axis, despite having a beautiful anterior and posterior rexis. So finally, to conclude concerning the surgery in infants without IOL implantation, 6 millimeter anterior rexis, 6 millimeter posterior rexis, good anterior vitrectomy, you're gonna have a successful surgery. And after surgery, look here with magnification. The capsular ring will contract. It's gonna be a beautiful capsular support for future secondary intraocular lenses. The 6 millimeter axis will be a 5 millimeter capsular support suitable for secondary IOL implantation. And sometimes this beautiful ring, when it is thin and when you implant the secondary IOL in the sulcus like that, you can even perform optic capture technique in these cases. This is concerning the surgery. The last issue, how to fit these babies with glasses after surgery. In cases of bilateral congenital cataract and those who are going to be fitted with aphakic spectacles are going to be fitted immediately after surgery. The power of the glasses. If the baby is less than 2 years, aim for 2 diopters myopia. For example, if the refracting is plus 15, fit the glasses with plus 17. And if the baby is more than 2 years of age, so aim for 1 diopter myopia in his glasses. And these are the perfect frames. You have to choose these frames. All plastic, beautiful fit here at the nasal bridge, and they should cover the eyebrow. Don't use these frames. They are not suitable for aphakic correction. The rectangular frames, the conventional frames, they sag down, they pop up, they tilt when they are fitted with the aphakic spectacles. This is not an ideal fit for aphakia. This is the perfect fit and the perfect frame you have to choose. They have advantages, actually, these frames. In very young infants, when they are fitted with very high pluses, reaching plus 20 diopters, they don't sag down and they are not that heavy. They fit in all faces, in thick faces, in thin faces, like that. Unlike the conventional spectacles, look here, they tilt when they are fitted with the high plus lenses. They also have the advantage is they have this beautiful bow. there is a sort of a distance between the eyelashes and the frames when they are fitted with the high plus lenses. And they have the advantage when the baby is lying on his back, they don't pop upward. And this is actually a beautiful advantage in the infants with cerebral palsy. They are lying most of the time on their back like that, and still the frames are fitted perfectly. This is another baby with cerebral palsy, and the conventional frames just pop up like that, but these frames, they remain fitted to their faces. They have another advantage in cases of Down syndrome. You all know that Down syndrome with the congenital cataract here, they have flat nasal bridges. These frames fit perfectly to their nose despite having flat nasal bridge. And also, Down syndrome, they have poor neck support, but still the frames are fitted perfect. Look to the conventional frames, they tilt easily. Another advantage to this frame, the infants with congenital cataract and also associated with ear anomalies. Look here, there is an abnormality in the ear, but still these frames fit ideal. You have to choose the size of the frame. It is important. This is a too large frame despite being a beautiful frame. This is the ideal size of the frame to choose. It should not be too large, it's not be too small. This is a beautiful frame, but too large, and this is the ideal size. The type of the lens, you have to choose it by yourself. The biconvex glass is too thick and too heavy. You have to choose, and it also touches the lashes of the infants. You have to choose the lenticular type of the glass. And they are usually convex concave or plano convex. And you choose to put the power on the anterior surface of the lens. Why? In order to make a distance between the lens and the lashes of the baby, and they fit perfectly. Can you see? This is a +20 lens, and this is a +20 lens, and there is a space between the lashes and the lens. And they have advantages in that a beautiful fit, even in the preterm babies having congenital cataract. And those with bilateral pseudophakia, you have to fit the babies with a bifocal spectacle or a multifocal fitted with +3 diopters. And you have, of course, to start the amblyopia therapy in cases of unilateral cases. Maybe you're going to find it very difficult in the start, but you have to persist. They will sleep. This is a baby with sensory exotropia after surgery. Starting the amblyopia therapy after surgery, shouting and yelling and crying, but they surrender at the end. And here the same child, 5 years after surgery, she's acquainted to the amblyopia therapy. And you have to continue this amblyopia therapy until the age of 9 years. And you have to make a sort of a training exercises for near work. For example, this child persistent on doing the amblyopia therapy 10 years after surgery, having straight eyes. This is another baby. He did the cataract surgery at the age of 6 months. Here, 1 year after surgery, straight eyes. 4 years after surgery, good amblyopia therapy, straight eyes. 6 years after surgery, 8 years after surgery, still maintaining straight eyes. Another baby with unilateral congenital cataract and sensory exotropia, immediately after surgery, fitted with the spectacles and starting amblyopia therapy, 10 years after surgery, attaining straight eyes and a perfect vision, despite having a unilateral congenital cataract. The last issue is that you have to go for a very long-term follow-up exam. Congenital cataract, 10 years after surgery, she's fine. Immediately after surgery, 15 years after surgery. Immediately and 17 years after surgery, she's doing fine, but it is not always like that. This is before surgery, 4 years after surgery, 6 years after surgery, and 10 years after surgery and having secondary intraocular lens and doing perfect. Then we lost her during the follow-up period, okay? She came 17 years after surgery with this terrible picture of high myopic glasses and exotropia. This is not a myopic shift. The myopic shift will not occur after 10 years. This is because she developed secondary glaucoma. So secondary glaucoma may occur years and years after surgery. So in Alexandria University, we follow up our cases for life. I did this baby, this one, not that one, when he was an infant. And then 20 years later, I did his baby, bilateral cataract surgery. I did this lady when she was a girl, and then 20 years later, I did her babies to surgery. So finally, to conclude, when you have pediatric cataract, or if you're going to work pediatric cataract surgery, it's a life commitment. You have to go for early diagnosis, diagnose the systemic anomaly if it is present, provide the suitable surgical techniques. Please ensure long-term follow-up exams because complications may occur years and years after surgery, and you have to be very compliant and ensure the compliance of the parents with the amblyopia therapy, because without amblyopia therapy, it's as if you did nothing in order to perform a successful surgery in these adorable infants. And thank you very much for your kind attention.
Thank you very much, Dr. Nihal. That was amazing. Such amazing experience and depth of knowledge, and it was fantastic. I'm pretty sure probably this presentation has reached to many people and will probably definitely make use of your wisdom and your pearls. There are a few questions. We'll come to the questions at the end if that's fine. Our next speaker is Dr. Tinley. Dr. Tinley is going to talk about pediatric strabismus. Dr. Tinley, over to you, please.
Good evening, everybody, and welcome to Cape Town. I want to share with you a few simple tips and background to pediatric strabismus and share my experience of this amazing profession that we're all in. So a lot of people are intimidated by strabismus in children, but it can really be easy if you stick to a few simple rules and classifications. Today we're going to focus on esotropias and exotropias that are comitant, because the incompetent deviations in children are relatively uncommon. Although you can classify squints in very different ways, they really are a continuum of disease, and a squint doesn't always obey the rules of or textbooks. The content of my talk is going to describe the types of squints we see in Cape Town children. Obviously, if you're living or working in other parts of the world, your squint profile may be different. We're going to talk about a simple clinic routine workup of children with squints and give us a classification of both esotropias and exotropias. I'm also going to show you an example of how I do a medial rectus recession, which is probably the most common squint operation that we do in our unit. In Cape Town, we see mostly esotropias. 70% of our children present with esotropias. And you can see the minority are paralytic or strabismus syndromes. This is a picture of the children playing in our clinic. And in South Africa, most of the children who attend our public hospital are either African ethnic origins or mixed race origins. As I said earlier, your esotropia to exotropia ratio may vary according to where you're practicing in the world. In Asia, they see a preponderance of exotropias, whereas in our communities and a lot of the African and Western world, esotropias predominate. So when you're investigating or being asked to see a child with a squint, it's always important to start with asking the mother what the presenting complaint is. When she noticed it beginning and whether or not the eyes were convergent or divergent. A birth and perinatal history is important because you want to know if the child had any neurological insult or perinatal hypoxia, which might be contributing to their squints, or any previous medical history as may guide you as to why the child may be squinting too. Oftentimes, children have a family history of strabismus, so this is important to evaluate early on in the workup. People often feel pressured to find the diagnosis and measure the angle immediately when confronted with a child with a squint. But remember to observe the child from a distance, smile, be playful, and make the consultation fun and relaxed. It's always important to have a lot of toys that are interesting and colorful to help distracted children when you're trying to assess their vision and get an appreciation of their angles. It's not always important to measure the actual measurement of the squint until you're preparing to operate on the child. When it comes to the motility examination, I always criticize or complain at my registrars or my trainees when they don't use the right documentation for the ocular movements. And it's important to take note of the ocular movements in the primary directions of gaze, all 9 directions of gaze, and that makes you much more easy to decide what operations to do and what muscles to operate on. These are the standard classifications or documentations for underactions and overactions, and it's basically based on the percentage of limitation of abduction or adduction in the eye. So -2 would be a 50% limitation of abduction in this eye, and -4 would be no movement in abduction whatsoever. There are a lot of abbreviations to get used to when you're looking at orthoptic reports and strabismus documentation. But these are the ones that we use commonly in our unit, and they really help make the length of your clinical notes and your documentation shorter and more succinct. For your examination, obviously an anterior segment exam is critical before you go on to pupil reactions and cycloplegic refraction. In children with esotropias, it's important to do an atropine refraction so that you can elucidate the full hypermetropic prescription. Fundoscopy is always important to make sure there's no organic pathology, or fundal pathology. Let's just talk about esotropias quickly. So the classification I use for comitant esotropias are the following. I divide comitant esotropias into 2 groups, accommodative and non-accommodative. A fully accommodative squint is one that corrects to less than 10 prism diopters with full hypermetropic correction. And a partially accommodative is if you have a residual deviation of more than 10 prism diopters. In non-accommodative squints, there is either congenital, which means their onset is within 6 months of age in a neurologically intact child, or else acquired. In both esotropias and exotropias, there are sensory categories for children with organic pathology preventing fusion, and also children with neurological impairment, which result in the squint becoming manifest. At Red Cross, we see a very large proportion of congenital esotropias as opposed to the accommodative one, and that may be partially based on the ethnic mix that we're seeing in South Africa. This is a very basic guide as to how we treat esotropias in our unit. So if you've refracted the child and they are found to be highly hypermetropic, you prescribe the full hypermetropic prescription. And if they correct to less than 10 prism diopters, then they're fully accommodative and you keep them in glasses. If after prescribing the hypermetropic correction, they still have a residual angle of greater than 10 diopters, then you may choose to operate for the residual angle. In children with congenital esotropia, we offer botulinum toxin to the medial recti muscles if the children present early at around 1 year of age. If they present after that, then we tend to offer surgery as a therapy. Be careful in children who present with esotropia after the age of 6 months, or otherwise known as acquired non-accommodative esotropias, because these children may have underlying neurological pathology. In children with sensory causes for esotropia, you should correct the pathology like a cataract, if possible, and then you can operate on them. For children who have neurological impairment, I tend to delay surgical correction because they usually have more or greater neurological or clinical issues than their squints. If they're very functionally impaired, then I don't tend to operate at all. When do we operate on the squint? Well, there are two reasons to operate on a child who is squinting. One is because the child is being teased at school, or the parents are concerned about cosmesis. And the other reason for operating on a squint is for functional reasons. So functional reasons are to preserve or regain fusion or stereo in a child. For esotropias, this mainly pertains to children who have congenital esotropias, where if you correct the angle before the age of a year, they may regain fusion and even stereo. In exotropias, you want to intervene surgically when the child develops amblyopia in one eye or starts losing stereo. For more information on botulinum toxin, I would advise please to refer to a lecture I did on Cyber's site, which outlines the background and exact methodology of doing toxin in children. Wherever you look, you will find several squint tables to guide you as to how much surgery to do for a particular angle of squint. I've chosen this table, which is a modified Marshall-Park squint table, because it's simple and it's an easy classification and nomogram, and it's out of a book by Dr. John Ferris from England called Strabismus Surgery. I just want to share with you quickly a surgical technique I use for medial rectus recession. So I'm going to stop sharing quickly. Can you still hear me?
Yes, we hear you.
Yes, we can.
Okay, so this is a very useful instrument I would recommend everyone getting who is attempting to do squint surgery, but it's called a fixation forceps, because you don't need to use tractional sutures or an assistant to hold the eye in position. It locks at the limbus, and you can put the eye into any position you need to. I mark out my conjunctival incision and do 2 radial cuts at the limbus. I tend to use a 7/0 Novosin or absorbable conjunctival traction suture, which helps give you good exposure to the muscle. Then you make pockets below and above the muscle that you're operating on, down to sclera. So it should be nice and smooth and slippery when you're opening up the pockets. Then you pass your squint hook under the muscle And I try as far as possible to avoid using sharp dissection. And a great tip is to use a cotton bud to sweep the tenons away from the muscle and expose the muscle nicely. Then I tear back the check ligaments and the wing ligaments so that the muscle won't be impeded when you recess it. We use monopolar cautery to cauterize any blood vessels that are potentially going to bleed on you when you start passing the sutures. Then I measure where the muscle is inserted so that I know how far to recess it. In all my squint procedures, when it comes to recession, I put a central locking suture posterior insertion to prevent a muscle slip post-operatively. And I tie that. Then I do a partial thickness suture to come to the end of the edge of the muscle anteriorly. And then a third width, one full thickness pass through the muscle and then locked twice. And I do the same on the other side. And then you carefully disinsert the muscle, making sure you don't interrupt your sutures. I always check on the back surface of the medial rectus muscle to take off some of the posterior capsule, which enhances adhesion of the muscle to the sclera if you're doing a hangback recession. A hangback is my surgical procedure of choice for recession surgery. Then I use a double diamond suture technique where you pass a suture at the superior pole and then again through the medial pole. You'll see it now. And then this suture technique is good because it keeps the muscle on tension and the muscle doesn't slip back when you're trying to grade and determine the amount of recession you're going to do. And then I think it's very important to neatly close the conjunctiva on both sides and bring the conjunctiva back to the limbus. And I routinely give subtenons Marcaine at the end of the procedure to aid with postoperative analgesia. Okay, we're nearly there, guys. Just a quick note on exotropias. So again, as with esotropias, most exotropias are comitant in children. We don't see many children with third nerve palsies or congenital cranial disinnervation disorders. An easy way to remember exotropias, as opposed to ESOs where you remember accommodative or non-accommodative, the two classifications to remember is intermittent or constant. the sensory and the CNS defects are consistent whether you've got an ESO or exotropia. So those are easy to remember. Distance intermittent exotropia is further differentiated into either true or simulated. And if you have an exotropia only at near, then that is due to convergence insufficiency. If your exotropia is constant, then again you divide it either into congenital, onset within 6 months, or acquired if the onset is older than 6 months. We need to just talk about the different types of intermittent exotropias in a bit more detail because it can be very confusing for novices to squint surgery. So an intermittent exotropia is if the child does look straight at times, either at near or at distance, but it intermittently deviates. So there are 3 groups of intermittent exotropia, 2 in the distance category and 1 in the near category. The near category is probably the easiest to describe because the exotropia is only present at near, and then that's called convergence insufficiency. For distance intermittent exotropia, the child is either only exotropic for distance and not for near, or the child is simulated where they are exotropic for distance and less exotropic for near, but when you put up a +3 accommodative lens, then the accommodation is abolished and the near angle approximates the distance angle. So that's also called a pseudo-divergence excess. In South Africa, most of the squints that we see that are exotropia have intermittent exotropia. When do I operate for intermittent exotropia? Well, there is a very well described revised Newcastle control score, which will aid you in deciding when it would be appropriate to operate for squints. But I tend to operate when the parents are noticing the squint more than 50% of the time at home, or if I see the child becoming amblyopic in the squinting eye, or if they start to lose fusion in the squinting eye. Usually, intermittent exotropias are monitored 6 monthly to see whether or not they maintain their alignment or whether they are decompensating. If the intermittent exotropia is true, in other words, it's always worse for distance than for near, then I tend to do bilateral lateral rectus recessions. If it's a simulated distance exotropia, which means that the angle for distance can be approximated to the angle for near, then I tend to do a unilateral recess resect on the deviating eye. For children with convergence insufficiency, surgery is not indicated and orthoptic exercises are recommended. For children with constant exotropias, surgery is usually the first port of call. So in summary, an easy classification for comitant esotropia, remember that are comitatives and non-comitatives. For exotropia, the 2 categories to remember are intermittent, which can be divided into distance or near, and constant, which can either be congenital, if the onset is before 6 months, or acquired. And remember, sensory and CNS defects are common to both types of squints. And the most important thing to remember about strabismus surgery is to have a good assistant. Thank you very much.
Yes. Thank you very much, Chris. Very comprehensive lectures. You make strabismus looks easy, and it's always my pleasure to be your assistant and your student. So please now allow me to introduce Dr. Irfan Khan. Before he will start his presentation, can we display the poll for Dr. Irfan presentation? Yeah, Dr. Irfan, you can, okay.
So hi, hello, hi, Dr. Irfan here. So I'm just just a poll, they only have like 2 questions. So the first question is that when do you inject an anti-VEGF? When an RP is zone, so when an RP is zone 2, stage 2 with no plus, or when the RP is in zone 3, stage 1, and the third one is, or when the RP is on zone 1 and stage 1 and 2. So that's the first question. If and the second, okay, great, good, thank you. That's very nice. Okay, pretty much on the same page. And can we have the second question, please? The second poll. Second poll: recurrence in ROP after anti-VEGF. How often should you screen them? Every week for 6 weeks, every week for 12 weeks, or every week for 16 weeks? Okay, all right, okay, so not bad. Okay, great. So we'll just go on to the presentation. Great, okay, let me just my screen share. All right, can you guys see my screen?
Yes, we can. Please go ahead.
All right. So I'm going to talk about the retinopathy of prematurity, my perspective. Moving on, the outline of the talk, I'll be talking about the map of ROP, the stages, when do we screen, who to screen, when do we start the screening, how frequently to screen, when to stop it, when to treat, and who to treat. Okay, and also how to treat probably at the end. So the most commonly used guidelines is from the Royal College of Ophthalmology, which was published in 2008. According to those guidelines, what we did is that they divided the eye into 2 zones. The first zone, which included the optic nerve and the macula. The second zone included double distance between the optic nerve and the macula. And the third is the most peripheral zone, which is more on the temporal side as compared to the nasal side. About the stages, the stage 1 is when the vessels reach and there's a demarcation line. The demarcation line is usually more whitish. Or if it's stage 2, when the demarcation line is more salmon pink, suggesting some neovascularization. And when the vascularization is quite profound, then it is stage 3. Stage 4 happens when there's involvement of the macula. Some books divided into 4A and 4B, which involves the macula and does not involve the macula. And the final, which of course we don't like, is stage 5 with total retinal detachment. Now, there's another term that we use is the plus disease. Now, when does plus happen? Plus disease is usually demarcated if you see dilated retinal vessels or they're very tortuous. The other indicator that you would see, which is a bad prognostic sign if your ROP is quite active, if the pupil does not dilate properly. This is again because of these dilated blood vessels. And the lastly is the vitreous haze. You have a look at the with the indirect view is quite hazy. You can barely see the blood vessels. Now, who to screen? All babies less than 32 weeks gestational age should be screened, and babies less than 15 or 1 gram. So it's the weeks and it's the grams. Anyone less than 32 and anyone less than 1500 grams. So it's quite clear on that. And when do we screen them? So less than 27 weeks, we see them when they are 30 to 31 weeks post-menstrual age. And if they are born between 27 and 32, we see them after 4 to 5 weeks. Again, if they are born, if they were born when they were more than 32 weeks, but a birth weight of less than 1500 grams, again, it's 4 to 5. So the thing to remember is that it's 4 to 5 weeks after birth, if they were born between 27 and 32. And if they were more than 32, but the birth weight is less, you again see them after 4 to 5 weeks. And any baby less than 27 weeks, a 24-weeker, 25-weeker, 23-weeker, irrespective, he's going to be seen on 30 to 31 weeks. Now, how frequently do we screen them? We screen them every week until, if they don't have any active ROP, we screen them until for the termination of where the blood vessels have reached. If they reach the aura or just short of the aura, you see them every 2 weeks. Okay, if there's no active ROP, no plus, you're not worried about them. You can see them every 2 weeks. But you see them every week if the vessels are only in zone 1 or they are in the posterior aspect of the zone 2. If you see some dilatation or some tortuosity, and again, if they have stage 3 disease, of course, you're going to see them in any zone. You're going to see them every week. Sometimes over here, the ROP is completely quite aggressive. So sometimes I even see them less than a week. Sometimes I see them after 3 days or 4 days if I'm quite concerned. Now, when to stop screening? So again, babies who are completely, who don't have any active ROP, once the blood vessels have reached the aura, they've reached zone 3, you can stop screening them. Another tip: most of the babies, they will reach up to 37 weeks. So if your baby is 34 weeks, 35 weeks, yeah, I would still see them at least up to 37 weeks. Some of the babies, they do reach up to the aura a bit more earlier, but just for completion's sake, they are still here. And if they're especially on oxygen, I would still see them again. If they are still there, if they're still in the NICU, I will still see them. But by 37 weeks, you should at least see them. Now, what happens to the other babies who had ROP? If they may had a demarcation line, or they may had some severity which kind of got better. If there's resolution of the ROP, there's no stage, the blood vessels have passed the demarcation line, there's no plus, then you can safely stop screening them in the NICU. But if you're worried, definitely bring them back to the eye clinic and see them over there once they are discharged. As a rule, what we do is that over here is that any babies who have not developed any ROP, we do see them in the clinic in 6 months' time. They are seen by the orthoptist and by the optometrist just to see if they are going towards what kind of refraction they have, what kind of visual behavior they have. If everything is good, they are then discharged and they are asked to come back when they're 4 years of age at least for a formal check. If they don't not have any active ROP and they've been fine, the parents are informed if they develop a squint to come and attend us. Those babies, again, who have developed ROP, who had treatment, we keep on seeing them every couple of months, checking on their refraction if they have become myopic or not. Now, when to treat? So zone 1 and zone 2, definitely you have to treat them. Zone 1, any stage. So any stage with plus disease, definitely you're going to treat them. Zone 1 with zone 3, a neovascularization with or without plus, you definitely have to treat them. Zone 2, stage 3 with plus, again, you treatment. And again, you can consider treatment, of course, if zone 2 stage 2 with plus disease. Now we have anti-VEGF. So most of the people would actually treat them quite earlier on. Okay, so this is just a graphical representation. So you can see that zone 1, stage 1 and stage 2 with plus disease, you treat them. Again, zone 1, stage 3 with or without plus, you definitely treat them. Zone 2, stage 3 with plus disease, you treat them. The tortuosity, dilatation, and the vitreous hairs, you treat them. And finally, zone 2, stage 2 with plus disease, again, you treat them. Now, most of our ROP work is done at Cornish Hospital. It's quite an old hospital. It's probably been here since the 1970s or maybe probably earlier on. Last year, 2019, we screened about 880 babies, and last year we treated about 32 babies. So it's quite a high volume NICU that they have. More than 85 babies are there at one present time. So I'm going to go on to the clinical cases, because looking through the books, of course, it looks quite simple. But when you go into the clinical practice, it's a completely different ballgame. The ROP over here in the Middle East, as far as is quite different as compared to the ROP that I've seen in the Western countries. They are more aggressive. We have a large number of IVF babies. They are born earlier. We have quite frequently we see twins and triplets. The birth rates are quite low, and the cases are quite challenging too. So this is a first case. So this was a 24-weeker. We've been seeing him again. He was started at 31 weeks. So I've just taken this slide from when we saw him at 34 weeks. His birth weight was 670 grams. This is the diagram that we use. All of the documentation, thanks to the NICU team over here in Cornish, everything is electronic. So we're able to draw all these diagrams on our on the medical record system. So so this is the zone, this is the stage. Often sometimes that's for my that's my own thing. I just draw it like that. That's in zone 2 and temporally, and zone 1 to 2 nasally. There was no yes, there was a plus. The RP version, there was multiple hemorrhage, and of course there was a need for treatment. We do the anti-VEGF treatments there in the same unit in a sterile room, which has positive pressure. So this is the RAD-CAM images. We have a RAD-CAM over there, thankfully. So quite a significant plus, quite dilatation, quite tortuosity, a lot of stuff going on here temporally. There's a bit of a hemorrhage over here. And if you look at the other eye, there's also a notch actually over here. Yeah, over here. So that notch, that's not a good sign, quite close to the macula. A lot of hemorrhages over here. So that baby was injected on the same day. The anti-VEGF that we use is Lucentis, ranibizumab. This is what we have. This is what we've been using for the last, I think, many years. Next slide. So, okay, so this is the same patient. This is 3 days post-op, had a good response to anti-VEGF, small hemorrhages there, still between stage 1 and 2, but much better. This was just after a few days, like 3 days. Again, seen again at 38 weeks, but weight is current weight is picking up, 2.1. At this stage, he develops some kind of hemorrhages around here, more on the nasal side rather than the temporal side, but still has a large vascular area. So at 41 weeks, we see him again. He's 2.8 kgs now. He's 8 weeks post anti-VEGF, develops hemorrhages now on the temporal side. There's some, again, hemorrhages over here. So at this stage, we decide that he probably needs a top-up of a laser at some stage. We see him again. This is, we left him with that, see him again after a week. Now things are a bit more worse. He also has some hemorrhages on the nasal side too. Tufts of envy. The baby was quite medically quite sick, and so the plan was either should we inject him again or should we do a laser. I am more favor of a laser. I don't like to inject the second time. This is him. The same case for the 2 weeks, 7 weeks post anti-VEGF. There's some tortuosity, some dilatation over here, some activity over here. Ridge is a bit slightly forming up over here, a bit of hemorrhages over here. The other eye is slightly better. Probably the hemorrhages are not there, but there are a few popcorns over here. Again, the view was terrible, so not a good view at all. But anyway, so what next? Should we observe? Should we laser? Should we do an anti-VEGF? So luckily the patient was going for a VP shunt and the GA, so that made our job much more easier. The patient had laser done the very next day, and that solved our problems. I don't have any post-laser pictures. Baby is quite big enough for now. She needs probably another GA to get another RAD-CAM images, but so far she's doing well. There's a mild cycloplegic refraction of just -1 myopia, but so far everything is doing well. This is the second case. Second case again at 23 weeker, 5 days, 500 grams. And we're seeing her at 32 weeks. So she's again between more like an AP ROP, anterior posterior ROP picture. Vessels are in zone 1 to zone 2. With stage 2, there's a bit of a pre-plus there. And this stage we decided, of course, we need to do examine her again, and we do a anti-VEGF the next day. Sometimes due to the large number of babies, we see about 20-25 babies, we see them and then we inject them the next day. So this is the picture over here, quite a hazy view. So you can see it's not that dilated, but they're quite quite tortuous there, quite tortuous over there. And this is quite a short distance there, a big avascular area here. So again, over here, you can see the tortuosity over here, and again over here. So I decided to inject her at that stage. So, so this is at when she's 32 weeks. So she had an anti-VEGF, and we see her after 36 weeks post anti-VEGF, doing well, a large avascular area. So I always keep these, I'd always put these things on the nose just to remind myself, look carefully for recurrence. So, so again, we see her after 39 weeks. This mild recurrence, we see a bit of a hemorrhage over here, still in stage 1, still quite large avascular zone, still in zone 2. And this is the picture, this is there. So this is now, she's at 42 weeks. It's quite a significant popcorns over here. The ridge is forming up, getting thicker, starting to turn over, a lot of blood vessels over here. So at this stage, we decided, okay, that's fine. She's going to have a laser. So a recurrence after anti-VEGF. In our experience that we've seen is that with the Lucentis, the recurrence of RP is seen just kind of after 5 weeks. I think majority of our babies out of those 32 babies which were treated, again it's a half to half, 17 of them underwent anti-VEGFs, and the rest of them were lasers. We do avoid the second injection, the anti-VEGF, because I just think that is a large avascular area that needs to be dealt with. So at the end of the day, anti-VEGF is a medication. It will wear off at some stage. So again, we try to laser if the vessels are midway zone 2, or if they've passed zone 2 with stage 3, then we offer laser. This is just an example, a baby that we've been following up. She was a 26-weeker, birth weight was 790 grams. This is she at 37 weeks. She had developed a good bit of plus. The vessels are quite tortuous. She managed to reach quite far up to zone 3, but over here, he started to develop some hemorrhages over here, a lot of peripheral branching over here, and a bit difficult to see over here. So again, if you do an anti-VEGF here, of course, you're gonna need to do something here. So, I mean, something later on. So we decided, okay, let's just finish the job and just do laser over here. So she ended up having just about probably 800 or 900 shots in each eye, and she's fine. She hasn't developed any recurrence. Talking about recurrence and talking about laser, this is another case, again, 26-weeker, 560 grams. So this baby, this is images at 40 weeks. We didn't do any treatment for this baby now. So over here, she still has a demarcation line. There is a bit of a fibrosis over here. But look at the activity. There's not much of branching as compared to the previous one. There's a lot of branching over here. There's not much of branching over here. There's a bit of clear area over here. The fibrosis is there, but again, there's some area which is missing over here. So these, and again, if you look at the posterior, I don't have a full picture of the posterior, but look at the blood vessels over here. They're not that dilated. They're not that active. So these babies, you don't have to inject them. Definitely, you can leave them. You can leave them and see them after every couple of weeks. This baby eventually fully vascularized. She was discharged from the clinic, and then she came. So discharged from the NICU. She came to the clinic now, and this area is all filled up. Even if they leave a tiny bit of an avascular area, I wouldn't be worried about that. Well, nothing happens to that. But if it's a large avascular area, and you have to do something about it. Case 5, this is another interesting case. This baby, she just squeezed into the RP criteria. She was 30 and 5 days. Her birth weight was far above the criteria. She just squeezed in. When we had a look at her, she had quite a tortuosity and a very large avascular area all around here. And she also had, so I'll tell you that we did laser for her next day. This is her soon after the laser. Look how the blood vessels have now kind of thinned off. The activity has completely died off. And so she also had a metabolic condition. She methylmalonic acidemia. I tried to look it up. I couldn't find much, but it's an unusual retinopathy seeing at quite a late stage, 30+5, and with the 1.8 baby. So anyway, the concept was the same: large avascular area dilatation. What will you do? You're going to laser it. So we lasered this baby. This baby is doing perfectly fine. Case 6. So when you talked about the anti-VEGF, this is what I mean, that this baby actually had an anti-VEGF treatment somewhere elsewhere. She was born at 27 weeks. Birth weight was 800. She received an anti-VEGF in both eyes. This eye did relatively fine. I couldn't go beyond the periphery. This is a different camera that we use. This is the Neonethra camera. Pretty good camera, relatively much less expensive. So if you're looking for like a camera, this can be your choice. So coming back to the case, so she developed a very unusual large fibrotic, this fibrous ridge here. The retina was all tented up. It's a bit difficult to see over here. Retina was all tented up. Still had a large avascular area. So I decided to, of course, the source is still there. That needs to be lasered. So we lasered here, and then we lasered also in front of it, just so it doesn't detach. I often do a red cam after the laser just to see for any gaps over here. Here are gaps. So it's quite a useful tool. If you have a red cam, always you can use it for after laser. It gives you your areas that you've missed. So I had a discussion with our retinal colleague, and then we decided, okay, you know what, let's do a buckle over here. So this patient ended up having a buckle. Patient is fine. It's been more than 1.5 years. The retinas are attached, and she's doing pretty well. The other eye, I don't have pictures for the other eye, but I also lasered her avascular area. Another case, these are twins. Both of the twins were of 26 weekers. This is 850. The other twin was a bit more lighter. So the 851, he has this unusual hypopigmented area, which we couldn't figure out what it is, but it has never changed since it's up till now. So this is him. He's 26 weeker. Now he's 36. Large avascular area. There's a demarcation line with some fibrosis over here. I wouldn't say it's kind of elevated there. It's kind of more like, sometimes I get confused. I mean, between a ridge or a demarcation line, then I usually write it's a flat demarcation line, a flat ridge, or it's an elevated ridge with. So this is more like a flat ridge. Now this guy, he lost follow-up. I'll tell you what happened to the twin. The twin ended up having treatment, but this guy, somehow the parents didn't bring him, and he comes now at 45 weeks. So that's the posterior pole, bit of tortuosity over here. But look at what's happening over here. This is the periphery. There's that same white spot over here. This spot, same white spot. He has a more like a vitreoretinal tuft, where a lot of blood vessels around here. So almost like an FEVR kind of like picture, So the pictures were taken. RedCam is a fantastic tool, or any image is a fantastic tool, because in my opinion, pictures can take say 1,000 words. I often show them the pictures. The parents get very quickly convinced. So this patient ended up having laser. This was just done recently. Just because of that area, that suspicious area, which I was worried about that. So I did 3 rows of laser just in front of it, so it doesn't, because with any your intervention, you're going to cause fibrosis. There's going to have some kind of contraction. So I was worried about that. So I just put 3 rows of laser over here. Now, what happened to the twin? The twin, she was 600 grams. She quite earlier on, she had active ROP changes. We followed her again, and again she developed some activity over here, a lot of branching over here, still slightly elevated, not that much impressive. But then again, she developed some popcorns over here, some hemorrhages over here. This is at 37 weeks, and then she ended up having a laser, and again she did fine. This is another case, a 24-weeker, 700 grams, seen at 37 weeks and 5 days. Some tortuosity on the posterior pole. Again, we have this ridge over here, a bit elevated over here. Sometimes you can see a bit of that darkness over there. That's more of the shadow of your the light. So you can see that it's a bit elevated there. So, but strangely enough, the patient also had a very strange, I've never seen this before, but a very strange, thick fibrotic kind of ridge there, which kind of extended here. So now, I mean, this is the first time I've seen them, but I've seen them a few now. So again, I mean, if you put an anti-VEGF here, you may get an exaggerated response. They may end up with that large fibrous ridge that I showed to you earlier on. So we ended up lasering this patient again. It's a bit difficult to get the shots over here because it's already white and it's a bit difficult to see white against white. But you increase your power up, just to be careful. Do not laser the healthy retina. Just keep on going over here, and of course, if keep on going over here, and you do get some burns, and then, but you could do some heavy laser over here. This is what we did. She ended up pretty all right. So changes in my practice after I've coming here. Anti-VEGF, if you want to use anti-VEGF, better to use it earlier on. If you use it later on, I think we get a lot of fibrous changes, and you can get a lot of fibrovascular changes, which can also ultimately lead to a traction retinal detachment. If you're doing an anti-VEGF, the job is not done. You have to look for recurrence. Again, for us, what we've seen is that after five, going on 6, 7, you will see some recurrence there. So if any signs of recurrent hemorrhages there, you do laser. Again, if you have a large avascular zone and you do laser them and you finish the job rather than seeing these patients in the clinic. When they're bigger, they're difficult to be examined, and often the parents are there. You're putting a speculum inside. The parents get worried that what kind of weird instruments you guys are using. It's easier when the ROPs are done in the NICU. So again, just be wary about the anti-VEGF. You know, it's easy, I know, to do an anti-VEGF and that's it, finish the job. But I think the job is not done. You still have to look for these strange kind of changes which can cause problems. Again, for the avascular retina, late recurrence, laser them. So in summary, current RP guidelines are good enough for high-risk babies. Screening interval may have to be shortened for high-risk babies. As I said, sometimes I see these babies after 3 days, 2 days, or 4 days, and believe me, you do see a lot of changes during that short interval. And the thirdly thing is nothing kind of for you know. But if you're not doing much ROP rounds every week, it's better to have a look at images. You know, the American Academy of Ophthalmology has a fantastic interactive tool. So there's no harm in looking at these images again and again and again, because you know, photographic memory, you know, is pretty much is pretty good. As these cases are more important clinically, you have to see them again and again to recognize those small changes, as it's a very time-sensitive procedure. And again, if you're thinking about a treatment plan, you should think about the treatment plan which has a good safety profile. So that's all me now.
Thank you very much, Dr. Irfan, for sharing your experience. It was very comprehensive. So let's now answer the poll again.
That's great. Okay, fantastic. Can we have the second one, please, now? Okay, so great. Okay, all right. Okay, pretty much still the same before and after. Okay, so our fourth, we do have some questions. We'll touch those questions at the end. We have some questions for Nihal and also for Christopher, but let's do Dr. Abeer's talk. And so over to you, Abeer. Abeer is going to talk us. Okay, here we are. She's already there.
Yeah. So let's do the poll. Okay, can you see my screen now?
Yes, we can.
Okay, very interesting. Okay. Hello again, everyone. Today I will discuss managing extreme VKC. So why this topic? Why did I choose VKC? Because it's a chronic inflammatory disease of ocular surface and one of the worst type of allergic conjunctival disease. Because of its chronic nature, it can damage the cornea, resulting in sight-threatening complication if left untreated. I will highlight the classification of VKC, staging and grading system, the stepwise approach of VKC, medical and surgical, and at the end, I will focus on the shield ulcer, the most severe form of VKC. Why extreme VKC is serious? Because it can lead to corneal shield ulcer. It can cause amblyopia due to corneal scar. It can lead to photophobia, and photophobia is the worst symptoms which affect daily life activity. And it can cause steroid-induced glaucoma and cataracts. Staging and grading of VKC is very important for the management plan. We have to ask the patient or the parent about the severity of symptoms. We divide it into mild, moderate, and severe. In mild, the patient or the parent will report discomfort, which were just noticeable. In moderate, they will report discomfort, but does not interfere with daily routine activity. While in severe, they will report disruption of daily routine activity and patients staying at home most of the time. Each visit, I'm asking the parents about compliance. Also, I ask a history of age of onset of the disease, history of atopy such as bronchial asthma, eczema, allergic rhinitis. I ask about seasonal variation and the duration of the condition. I ask about family history of allergic disease. In each visit, I ask about presence of hyperemia, itching, tearing, photophobia, mucus discharge, or any other referred symptoms. This table is very important to help us or to guide us for VKC grading. So we have 5 grades based on the symptoms and the sign. Grade 1, where patient has mild intermittent VKC, they report mild conjunctival hyperemia, absence or mild conjunctival secretion, mild to moderate papillary reaction, no Truntus dot, and no corneal involvement. Grade 2 VKC, we have intermittent and persisting. Patient will report mild to moderate intermittent or persisting symptoms. They have mild to moderate conjunctival hyperemia, mild to moderate to severe conjunctival secretion. They might have moderate to severe papillary reaction. They might have also few Truntus dots, and they might have SBKs. Grade 3, the severe form, they will report moderate to severe persisting symptoms, moderate to severe conjunctival hyperemia, moderate to severe conjunctival secretion. They might have severe papillary reaction, and they might have few Truntus dots and SBKs. The grade 4, the very severe form, which I will focus today, they will report severe and persisting symptoms, moderate to severe conjunctival hyperemia, severe conjunctival secretion, giant papillae or cobblestone papillary reaction. They might have numerous Trantus dot and corneal erosion or ulceration. Grade 5 is the involution or resolution of the disease. Now I will explain the stepwise approach. Each visit, I have to educate the parents. Each visit, no matter how many times I explained before, I'll tell them again about the comfort measure, remove all offending allergen, cool compresses, and lubricating eye drops. For grade 1, mild intermittent, I'll give the patient occasional anti-allergic drops, occasional lubrication, and I discharge the patient. For grade 2, moderate type, intermittent or persisting, the best thing is the dual action, the drops with muscle stabilizer and antihistamine. Usually I follow the patient every 6 to 9 months. For grade 3, the severe form, I prefer to start with the weak form of steroid like FML or Lutamax as a first treatment. If steroid failed, I'll consider topical steroid sparing agent such as tacrolimus 0.03% or cyclosporine A. For grade 4, the very severe form, I'll give more potent steroid high dose, and also I'll consider steroid sparing agent, the topical drops. In grade 5, this is involution or resolution of the disease. I'll prescribe occasional anti-allergic drops, occasional lubrication, and I discharge the patient. Now let's move to the main topic of our talk today, managing extreme vernal keratoconjunctivitis. I'll talk specifically about shield ulcer. And in shield ulcer, it developed due to the mechanical friction generated by giant papillae. This friction will lead to microcorneal trauma and later on can evolve to corneal shield ulcer. This shield ulcer is toxic. The immunofluorescence assay have shown presence of toxic eosinophilic granules, major basic protein, in the inflammatory debris of the patient with shield ulcer. This toxic eosinophil can release inflammatory mediators such as histamine and activated neutrophil. And these chemical mediator interferes with the epithelial anchoring mechanism, leading to delay reepithelialization. So to summarize, the two hypotheses for shield ulcer is mechanical hypothesis due to the giant papillae rubbing the upper part of the cornea, and the other hypothesis is toxin hypothesis, where the toxic eosinophil produce chemical mediator and induce corneal epithelial damage. Let's move to the grading of shield ulcer. It's very important to be familiar with the grade of shield ulcer to be able to treat. We have 3 grades, grade 1, grade 2, and grade 3. In grade 1 shield ulcer, the cornea is clear, but when you put fluorescein, you might find that the patient has diffuse epithelial erosion or macro erosion, or even epithelial defect with transparent base. While in grade 2 shield ulcer, patient will have epithelial defect with more opaque margin than the base, or epithelial defect with more opaque base than the margin. While in grade 3 shield ulcer, the ulcer is more opaque and they have elevated plaque. The main aim of managing shield ulcer, number 1, to promote rapid reepithelialization by preventing release of toxic inflammatory mediator. Number 2, to prevent direct mechanical trauma resulting from the large cobblestone papillae. And finally, to provide a healthy environment for corneal epithelium. So how to treat the shield ulcer? The main aim is to achieve rapid reepithelialization. When I did literature review, a lot of treatment modalities such as medical treatment, either by topical corticosteroid, anti-allergic, or steroid-sparing drops like cyclosporine. Other option is surgical debridement, superficial keratectomy, amniotic membrane transplant, or excimer laser. The common guidelines for grade 1 shield ulcer, where the cornea is clear, as I mentioned, only diffuse punctate erosion or macro erosion or epithelial defect with transparent base. The recommended treatment is medical treatment. So we have to start with topical antibiotic, topical steroid, and lubrication. It's very important to follow up the patient weekly until reepithelialization. While in grade 2 and grade 3 shield ulcer, surgical debridement of shield ulcer plaque is recommended, and early surgical debridement is effective treatment because it interrupts the course of the disease. So for grade 2 and grade 3 shield ulcer, I book the children to remove it under general anesthesia. I scrape the base and the margin of the ulcer using number 15 surgical blade. Usually only debridement is enough, but sometimes the plaque is very strongly adhered to the cornea. So we have to carry out superficial keratectomy using either crescent blade or surgical blade number 15. After removal of the plaque, I have to evert the upper eyelid, looking for any significant papillae, and I inject supratarsal steroid 0.5 ml. Either it's based on your availability in the theater, either you can inject dexamethasone 4 mg per ml or triamcinolone 40 mg per ml. And after that, I apply bandage soft contact lens and topical antibiotic. Keep in mind that coexisting bacterial keratitis can occur, especially with the patient with pain and suspicious clinical sign. You should go ahead with debridement and microbiological workup for direct smear examination and culture examination, and treatment should be modified based on smear and culture results. My routine post-operative order after surgical debridement, I cover with topical antibiotic. Once reepithelialization starts, I can start the topical steroid. And also, I always consider steroid-sparing agent. For example, tacrolimus, 0.03%. It's very safe in literature review. We can give the kids twice a day for 3 to 6 months. And it's especially helpful in case of refractory VKC, ocular hypertension, and glaucoma. Take-home message for shield ulcer. For grade 1, the recommended treatment is the medical treatment. For grade 2, early surgical debridement can achieve higher reepithelialization rate than medical treatment alone. While in grade 3 shield ulcer, early surgical debridement or superficial keratectomy can achieve rapid reepithelialization and better visual recovery. Our aim in extreme VKC is prevention of complications and restore good vision by prescribing potent steroid, ascertaining compliance to medication, close regular follow-up, and prompt surgical intervention when needed. And I want to conclude that ultimate goals in shield ulcer treatment based on the grade. If we treat grade 1 with medical treatment and grade 2 and 3 with early surgical debridement, we can achieve decreased reepithelialization time, restore vision, and the most important, to minimize complications such as amblyopia due to corneal scarring, bacterial keratitis, and steroid-induced cataract and glaucoma. Thank you very much.
Great, fantastic, Abeer. A very great presentation, very methodical. and stepwise approach to BKC, which often can be confused with viral ulcers, and often it becomes a dilemma, and you see patients quite late. So very well presented. We have a few questions. Dr. Nihal, we'll start with you. There were a few questions that came up. First, oh, sorry, there's another. Okay, the poll. Let's do the poll first. Yeah.
The audience have.
So,
yes, so
all
still,
right.
okay, it's 50-50.
All right, okay, good. So Dr. Nihal, there are a few questions for you too. Dr. Nihal, just a question from the audience there. They were asking about the type, the glasses that you were showing, the FAK glasses. Is there, do you know the brand of them? What are they called?
Yeah, well, there are actually several brands. One of them is called Solo Bambina, and there is another one, but I forgot actually the name. I'm going to go and look to my office tomorrow because there are several types or several brands actually. I just presented the how it looks, whatever the brand is.
Sure.
The right frame for the aphakic children. But
okay, perfect.
I'm going to email you with all the brands.
Sure. We can always look. There was another question, is that if you see a patient, a baby who presented in the second week of life, and he has a pretty much more like a lamellar cataract, but when you dilate him and he still has a bit of a red reflex, do you, obviously you're going to wait for about 8 to 10 weeks. What's the ideal time you want to operate on them? And do you use any dilating eye drops just to get some vision stimulation, or does that have an effect?
Well, actually, I operate cases not before ever 2 months of age, when they enter in the 3rd month, because we realize that the incidence of secondary glaucoma decreases massively when you operate in the early 3 months. So you have to weigh it. Is it amblyopia you're afraid of, or the secondary glaucoma? I think the secondary glaucoma is much more blinding than the risk of amblyopia. So this is a personal opinion, and that's why I have a go. And that's why the incidence of secondary glaucoma in Alexandria University, it is about maybe 4 or 5% compared to a higher percentages in other places.
That's correct. And what? Sorry, say it again. The last sentence.
I said that the incidence of secondary glaucoma is nearly 4%, which is less. This is more. The secondary glaucoma is more dangerous.
That's correct. Yeah, I totally agree. It's far more difficult to treat secondary glaucoma rather than treat amblyopia. That's perfectly reasonable. There was another question about post-op refractive adaptation. You mentioned it in your presentation already, that you give them the glasses as soon as possible.
Yes.
Do you wait for the stitches to come out, or take them out, or you just give them immediately on the first post-op day?
Immediately after surgery. I operate one eye and the second eye within few days, and then the very next day I fit them with the aphakic spectacle.
All right. Okay. Great. Okay. Perfect. I think there were. I think that's pretty. Oh yeah, the other one. Secondary IOL implantation. What is your preferred? If you do a newborn baby and leave him aphakic, what's your preference of when would you put a secondary IOL?
Parents are reliable and with the aphakic spectacles, and they are reliable with the follow-up exams. So I prefer to go for the secondary IOL implantation at the age of 4 years, just before school age. This will lower the incidence of IOL exchange in the future. because at this age, they will go to the nursery. They want to look for far and for near for drawing and near work. He will use this near work. And I cannot fit him with a multifocal or bifocal because these are high plus lenses. The multifocal and the bifocal are only available until you have a spherical equivalent of +10. But the majority of patients are more than 10 diopters to be fitted in their glasses. So how will they work with 2 glasses? So I'm forced to implant before nursery. That's why I implant at the age of 4 years.
Okay,
but
great.
They're not reliable with the glasses. At the age of 2, I implant secondary intraocular lens.
That's good. That's good. Fair enough. Does the panel have any questions? Christopher or Dr. B, you have any questions for Dr. Nihal?
A question for Chris, because this is always the discussion between me and Irfan. So in exotropia, does it really matter if we do BLR versus RNR? So does it really matter in the outcomes? So what is your opinion?
The truth of the matter is it doesn't really matter. And strabismus surgery is a dark art, and it depends on where you grew up and who you listen to and what technique you prefer in your hands. But it really doesn't matter which technique you prefer. It just seems to make sense for me that if you've got a deviation that's greater for distance than for near at all times, and despite eliminating accommodation, you would operate on the lateral recti rather than a recess resect.
Yeah, thank you very much.
Great. I think there's still no consensus between me and Abeer, you know. So yeah, if she wants to do an RNR, sometimes I want to do a BLR. So yeah, it's still going on. Christopher, there was one question from the audience. They wanted to know is that any specific reason of using atropine for your cyclorefractions is just because it's, and do you send the patients home with atropine? They come back after a few days to get that full cycloplegic effect?
Exactly. So often we do two-stage visits for children who present with squints. You know, unless they have organic pathology, there's no reason why you have to refract them the next day. So we tend to send them away. If it's an esotropia, send them away with atropine and to come back fully cyclopleged, because obviously for an esotropic child, you have to get the full hypermetropic correction. It's critically important to give that. So we use atropine in those instances. If you've got a child with exotropia, it's not that important to get the full hypermetropic prescription because you're not going to correct them fully anyway. So I'm happy to use cyclo for, you know, on the day of arrival for exos, but for esos, they must have atropine.
All right, great. There was one question about Botox. How long does the effect for Botox last in your experience, Christopher, for the diabetes?
The paralytic effect lasts for about 4 months. So you can't judge the success of your procedure until you've waited 4 months after the toxin injection to see whether or not the child, you know, has developed some fusion and is straightening up. But the success rates, you know, vary depending on how often you inject and whether the child has potential for fusion.
And if you want to operate on that same kid who's had Botox, would you consider measurements, at least 2 successive measurements, which are equal, or usually they are taken after 6 months, something like that?
I probably would take a measurement at 6 months because it's unlikely to change much after 4 months. But yeah, that's about it.
Yeah, all right. Okay, great. Okay.
Someone asked about my medial rectus squint technique and they didn't get all the steps. If that's the case, just email me or contact Dr. Abeer and she will send you the video link. It was just too long for me to show in full in the talk today, unfortunately.
Okay. Abeer, coming to Abeer. Abeer, there's a question for you. Do you put, there's a question about tacrolimus. Firstly, they wanted to know is tacrolimus 0.03 available in the UAE?
Yeah, it is. The one we use is the skin ointment, but even in the literature review, they showed we can apply the skin ointment into the subconjunctival fornices. So I'm not aware that we have ophthalmic, so I use the skin preparation.
Exactly the same here, yeah. So absolutely right. Another question about debridement. So if someone has a shield ulcer and they also have keratoconus, would you change or modify the way you debride, or would you carry on?
Because usually pediatric, we don't diagnose them with I have experience with the pediatric. So usually you have to do very superficial, you have to find your plane. So you have to go up to the Bowman's membrane and you just peel it off. I don't think there is any modification up to minor.
Yeah, I think you're absolutely right. It would be very, very difficult to judge or to see the grade of keratoconus in a patient who has shield ulcer. So I think probably, I think for me, probably I would just carry on debriding.
If you have a luxury of intraoperative OCT, so it might help you to do very careful dissection. But if you have,
correct, that's correct. So again, some of the units are getting it, so you're perfectly right. Yeah. There's a question about, do you put the tacrolimus on the eyelid or inside the eye?
So what I tell the mother, just put a tiny cream in your hand, then with the cotton bud, just invert the lid and put just little inside the foreign conjunctival. It's sting in the beginning, but then they will get used to it. It's very safe. I cannot remember any complication apart from tingling sensation. Yeah.
Someone is asking about after therapeutic debridement, would contact lens be beneficial? So I think you mentioned it already. You do put a contact lens on.
Contact lens, after 1 week, we have to take it off.
And in your experience, tacrolimus versus cyclosporine, which have you seen probably has a long-term beneficial effect?
Yeah, because I train in Cape Town, we use tacrolimus for everyone. And even in literature, tacrolimus has better effect than cyclosporine A.
All right, perfect.
Stings a lot.
Yes, sorry, I didn't get that.
Cyclosporine stings a lot.
Oh, that's correct. You're right. You're right. I think for a kid, probably if you put cyclosporine, he's never ever going to put that in again. That's correct. Yeah. All right, Dr. Nihal, there was one question about the use of multifocal IOLs. This probably would be for all of us. A use of multifocal IOLs in a bilateral, like a phakic, who's about now, school-going age. He's probably around, irrespective of the age. Would you consider that option now, since we have them now, multifocal IOLs, or no?
I don't think so, because, many adults are not satisfied. Still, some of them are not satisfied with the multifocal. So definitely it will not be a suitable issue concerning the children. I don't have experience, and I'm not convinced that one day I'm going to implant it in children.
Okay. All right. Okay. Great. Okay. Good. There's another question for Dr. Abeer. Sorry, I'm going back and forth between all of you guys. There's another question for Dr. Abeer. Abeer, they're asking about if you're getting a corneal opacity with a shield ulcer, does it mean that it's bacterial in nature, and how would you differentiate between, is it bacterial or is it non-bacterial?
So the only way is go ahead with your debridement, do microbiological study, send for direct smear and scrape. You have to do the proper way, especially if patient has suspicious sign of pain or hypopia. So we have to go with this. Yeah.
That's correct. That's a reasonable approach. If you're doing a debridement, why not just send the same sample and they can put it on their plate, see if any bugs are growing or not. All right. Okay, great. I think we've got most of the questions here. Sorry, Abeer, can you say it again?
Someone asked about the dose of ROP. I saw that question. So
oh, yes. Dose of ROP, we use 0.25 milligram, half the one of the adults. So in the syringe, there's usually the mark, which is for the adults. So it's actually more like guesswork, because the injection that we get, the pre-filled, we go via the mark and we go up halfway of it and then we inject the rest. So it's very difficult to calculate the actual dose of it, but we just go midway between the adult and the end of the syringe.
Yeah.
Irfan, do you have a preference for Lucentis over Avastin? Are you convinced that Lucentis is better?
Honestly, I don't mind I think probably it's what we have. In sick kids, we used to use Avastin, and over here we have Rani. So, but I think irrespective of that, the main point would be that, you know, the recurrence, which I'm a bit worried about that, most of it kind of we do it and we kind of like forget, and the exaggerated fibrovascular response. But as regards to safety profile, I think probably papers are coming out. Sometimes I get scared about these, what's going to happen to these kids, you know, mentally and all that stuff, you know. So I think because the Lucentis safety profile is a bit better. So if I had to choose one, I would go for the Rani.
We unfortunately don't have access to that. It's too expensive.
Yeah, I know. All right. Okay, great. Any other questions? Abeer, do you have any questions for Dr. Nihal or Chris?
Yeah, I have a question for Dr. Nihal, if you don't mind. So I noticed that the posterior capsulotomy, you do it with the tip of the needle and manual. Why not with your vitrector? What is the difference?
You know that your hands, what God created, is a gold standard. If you cannot master doing it with your hands, no problem to go it with the cutter. With your hands, it is much more controllable. You can go for exactly 4. And with your hands, you can manage all types of posterior capsule. Today, we did present just the simple case with extremely healthy posterior capsule, straightforward cases. But sometimes it's not like that. Sometimes you have plaques, you have defects, you have lenticonus. So you have to master that you can, with your forceps, perform exactly the 4mm rexes. But if not, you can definitely go with a cutter. So do whatever you master. It's not a must that you have to go with the rexus forceps manually by your hand, because not only the posterior capsule, some people prefer to go for the cataract surgery through pars plicara, and it is much more safe in their hands. Okay, fine. I prefer to go for the posterior rexus before IOL implantation. Others prefer to implant the IOL first and then go for the rexus, anterior approach. And others go through the pars plana. For me, these are difficult in my hands. It's much more easy to go that way. So as a conclusion, there are always choices. So whatever you master, go for it.
Can I ask Nihal one quick question?
Yes.
Do you always dry anterior vitrectomy? You never put the infusion on?
No, I go for infusion, but not from the start. And the infusion, you go in and out with it to prevent overhydration of vitreous, because when you go for overhydration, vitreous will come to you to the wound. You don't want vitreous to come into the anterior chamber and to the wound. You go and tackle it in its place. So dry vitrectomy first in order to lower the vitreous pressure, and then go by the infusion from the side port whenever necessary.
I understand.
Right. There was one question, I think probably you answered it. There was someone was asking Dr. Nihaltas to you that if you don't have a vitrector, I mean, I don't know what the answer, you know, what if you don't have a vitrector, what can you do?
I will not go for surgery. Because
that's like absolutely right. I think probably you're doing probably a disservice to that child. Yeah.
We've been actually observing the cases along that. I've been working in the pediatric cataract surgery for more than 27 years. And I'm telling you, I'm following up these cases up till now. So the conclusion is that the key of success of pediatric cataract surgery to have a clear visual axis is anterior vitrectomy, and not the size of posterior rexus. Anterior vitrectomy is a must. I don't believe that it is possible to leave the posterior capsule intact. I don't believe that you go for a posterior rexus and implant the IOL. Definitely, you have a formed anterior vitreous space. Lens epithelial cells, you did see in the slides that it moves over the anterior vitreous space and obstruct the visual axis. If you say that you don't see these cases, it means that you don't follow up the cases. You never see the cases years after surgery. So I'm telling you about by the practice, by real patients, what happened, and you saw photos for such complications.
This is, I think you're absolutely right. Most of your surgical decisions, they come with your experience. There are certain things that you do, when you start following your patients up for a longer period of time, then when you see the effects of your surgery that you've performed, then often you change your practices. So I think you're absolutely right. You're absolutely right about that. Great. Anything else? I think probably we've done all the questions here. We're just about 15 minutes over 10 o'clock. And do you want to do the closing remarks, Abeer?
I would like to thank you all. It was a great pleasure to meet all of you today. I wish that if we can continue, but I know this is your weekend. So thank you very much. Thank you very much, Irfan, Nihal, and Chris.
It was a pleasure speaking to all of you, and thank you very much. I hope we can do it again. It was lovely talking to you, Dr. Nihal and Christopher. We'll come to the conclusion about the BLR or the RNR at some stage.
We'll update Chris about it.
All right. Okay. Thank you very much, and have a good evening. Bye bye.